I'm Dr. Bayard Powell. I'm Director of Leukemia Service at Wake Forest Baptist Health. I'm here today to talk to you about acute leukemias, acute myeloid leukemia, and acute lymphoid leukemia, or AML and ALL. Acute myeloid leukemia, or AML, is the most common of the acute leukemias in adults. It makes up about 80% of acute leukemias. Patients with acute leukemia usually present sick. They present with one of three major findings. They present with infection from the lack of good, healthy white blood cells. So the white blood cells are the ones that help you fight infections. They present with anemia symptoms, so they're very weak, tired, fatigued, pale. Or they present with signs of bleeding, bruising, gum bleeding, symptoms such as that. A few people will present with bone pain, which is a sign of the rapid growth of these leukemia cells within their bone marrow, but most will present with one of the first three symptoms. Most patients with acute myeloid leukemia, we do not know the cause. But for a few patients, we know there are risk factors such as exposure to high levels of benzenes, such in the petroleum industry, or patients exposed to high levels of pesticides used in commercial farming settings, veterans exposed to Agent Orange in Vietnam are at some increased risk. There are also a group of patients that we know are at risk because of their prior therapy for other cancers. Some of the drugs, the so-called alkylator group, or radiation, or a combination of those, do make patients at some increased risk of developing acute leukemia. But for most patients, 98–99% of the time, we do not know what causes their leukemia. It is not an inherited disorder to our knowledge, and so it doesn't appear to run in families, so you don't have to think too much about your children, grandchildren, brothers and sisters, other family members developing acute leukemia. Even though we'll talk a fair amount about genetics in leukemia, these are acquired genetic abnormalities, so they're a result of leukemia or associated with development of leukemia, not something you were born with. So separate that out from your inheritance pattern, the fact that the chromosomes are actively involved in the development and in the prognosis for people with leukemia. When we look at your bone marrow under the microscope, we look at the number of these blast cells, or the immature cells. If it's above 5%, then we know that's abnormal, but we don't call it acute leukemia until it's above 20%. The group between 5 and 20 is a group we call myelodysplastic syndromes, or pre-leukemias, and we won't talk very much about that today. But if you have over 20%, you have acute leukemia. So you have A blank L. We need to know the middle initial. We need to know is it acute lymphocytic leukemia, which is more common in children, or is it acute myeloid leukemia, which is much more common in adults, making up about 80% of adult acute leukemias. And we do that by some special testing, something called immunophenotyping or flow cytometry, looking at markers on the surface of cells. We can do some special stains and look at it in a microscope, but we can usually determine that within a couple of days of your diagnostic bone marrow. Other things that we do at the time of your diagnosis, and even though they're not necessary to confirm your diagnosis, they're very important in your long-term outlook or prognosis. And that is through chromosomes or genetics on your leukemia cells. We will send those off, and it may take a week or two to get us back. It doesn't directly impact how we treat you initially, but it will have an impact on how we treat you with your follow-up treatments and how we follow you over time. Also, there are a group of molecular studies, and I won't go into naming those. It's a group of initials, largely. There's no formal names for those, but many of those actually now impact prognosis. And what we've done between the genetics and the molecular markers, if we've started to be able to individualize treatment for people with acute myeloid leukemia. We have a number of clinical trials now that are based on what molecular markers someone has. So we may delay your treatment for a couple of days to get those markers back to determine if you might benefit from additional treatment beyond the standard treatments. And hopefully, as we go forward into the future, we'll be able to individualize treatment more and more by choosing drugs that are most effective against your disease, and also hopefully avoiding toxicity of drugs that might not be effective. So it's just as important to choose drugs that might not be effective as it is to choose those that will work best for you. In acute myeloid leukemia, we don't stage patients. It's more important to determine do they have the acute lymphocytic leukemia or the acute myeloid leukemia and get those prognostic factors. We do try to determine for sure that you don't have certain subtypes, such as the acute promyelocytic leukemia, which is treated differently. So we try to determine what characteristics you have that will drive your treatment decisions, but there is no formal staging system for acute myeloid leukemia or for acute lymphoid leukemia. When we talk about treatment, there are a few things we should move into before we really get into treatment. First of all, when you came in, I said you likely were diagnosed because of some symptoms. So if you're infected, we give you antibiotics. If you're bleeding, we give you platelet transfusions. And if you're anemic and you're weak, we give you red cell transfusion. So that's what I could refer to as kind of the tune-up phase, where we try to correct what was your major problem and what is making you sick at this time before we get into the actual treatment of the leukemia. We'll be doing that in parallel, so at the same time that we're making your diagnosis, we'll be treating any major complications you have at the same time. We'll start now to talk about the treatment of acute myeloid leukemia, or AML. We talked about treating your symptoms initially. We also would usually put some type of central catheter in so you could get blood transfusions, get antibiotics, have your blood drawn from there, because you'll be in the hospital usually between 4 and 6 weeks receiving some treatment. So access, so you don't have to be stuck a lot, is very useful to patients. We will have you on some antibiotics to help prevent infections, and we'll frequently do some measure of your heart function, because one of the medicines we use can affect heart function. We want to make sure it's healthy to start with. So I try to break treatment down into 4 segments, and I'll try to, I say the same thing to our medical students, our residents, so I'll try to talk at a level I think all of us can understand. The first one is what I call the wipeout phase. Your job here is to wipe out the leukemia, and that's commonly involves 2 drugs. One drug runs continuously for 7 days, and the other drug's given as over a short period of time the first 3 days. So we call it so-called 7 plus 3. It's really, they overlap the first 3 days, so it's really 7 days of treatment. The main drug that runs for 7 days is called cytarabine, or Ara-C, and then one of the anthracyclines is used for the other 3 days, and it can vary. There are several different ones you can use. I won't go into great details about the drugs. Not a pharmacology course, I just want you to understand that component. The one that's given for 3 days is the one that can affect the heart function. Just like if you were spraying a weed, and I tell people sometimes having leukemia is like having a garden that's overgrown by weeds, and we got to wipe out all the weeds and let the good healthy seed cells grow back. And there's a lot of analogies as you go through this discussion with that. So once you spray a weed with weed killer, it doesn't die right before your eyes. So we give that 7 days of treatment, and we let it affect the bone marrow cells, let them try to reproduce and die, and then a week after we finish, so around day 14, we do another bone marrow test to see if the disease is gone. If we don't see with the eye under the microscope any leukemia left, then we've accomplished that first goal, the wipeout phase. And about 60% of people will have wipeout after the first course of treatment. So after 7 and 3, wait 7 days, day 14, get your results day 15, and they'll be wiped out. And then you go to the recovery mode, and we'll go to that. That's step 2. If the 40% of people that have some residual disease but have had progress, then get 5 plus 2. So 5 days of the one drug, 2 days of the other drug, wait a week and have another bone marrow test. And of those people, 40%, 3/4 or 30% of patients will be wiped out, and they then move on to the recovery phase as well. Of the 10% that still have disease, then you have to individualize treatment at that point, because that means their leukemia is fairly resistant, and that really has to be individualized and frequently may involve some clinical trials or some novel approaches. Once you get past that first course, the wipeout phase, let's move to cycle 2, which is, and to be quite blunt, is to help keep the patient alive. The biggest risk to people with leukemia is infection. Most patients survive their leukemia, but of patients who die from their leukemia, 85% of the time it's infection, and 10% of the time it's bleeding. 5% is everything else put together. So when you're on our service, you would think we're infectious disease doctors most of the time, because we spend a lot of time talking about infection. Everybody washes their hands to make sure they're clean. We have a slight dietary restrictions, and we have special air handling in your room to help decrease your risk of infection. We'll want you to wear a mask if you're out in the hall to decrease infection, and we'll want sick family and friends to stay home and call you on the phone. But that being said, we frequently can deal with those. We know almost everyone will have a fever sometime during the hospitalization, and they will need antibiotics. We deal with that on a regular basis, and we can get through that most of the time. But those are our big challenges. So during that 2 weeks between when that bone marrow is empty and we've accomplished goal 1, and when your blood counts start to recover, you start to repopulate your blood with good infection-fighting cells, during that 2 or 3 weeks, plus the time when we're waiting for your bone marrow to be emptied out, we're really focusing on those side effects. Number 1 being infection, number 2 bleeding, and then all the other things, adjusting all the other things around. We deal with nausea, vomiting. We do pretty well with that these days. Probably around 2.5 to 3 weeks from start of treatment, you will lose your hair, and almost everybody does lose their hair with this treatment. But unlike mine, yours is going to grow back. So relax, and it'll be beautiful when it comes back. The key thing is to have you get through this and have your good blood cells grow back, and your hair will come with time. The other side effects are largely related to medications, things related to antibiotics. Sometimes people can have rashes and other things that come along, but we've dealt with the major ones you deal with. So during that time period, we're helping you while you have no good healthy blood cells. We're giving you blood cell transfusions. Frequently you need red cells once or twice a week. You will need platelet transfusions 2 or 3 times a week to help keep you from bleeding. And that's really the focus of that period of time. The next major goal is to have you recover normal cells. Patients say when you tell them their bone marrow is empty after that day 14 bone marrow or that day 28 bone marrow, am I in remission? No. But when your blood cells start to come up and your white count gets up and you have good healthy white cells and your platelets come up and you have good healthy platelets, and then we will do another bone marrow test to show that the bone marrow is clear, you don't have any leukemia in there, and that's when you say you're in remission. Your blood's up, your bone marrow is clear, then you're in remission. That blood count recovery usually starts about 2 weeks from your last chemotherapy. So if you got 7 and 3, about 3 weeks from your last chemotherapy, about 2 weeks from that bone marrow that was empty. So if you got 7 and 3, you had 21 days to that, so that's around 4 weeks. And that's when I said earlier on you were in the hospital about 4 weeks. If you then get a second course, that pushes things back about 2 weeks, and you're in the hospital for about 6 weeks waiting for your blood counts to recover. When your blood counts recover, we're able to stop your antibiotics, send you home, let you recover some at home. Now you would think that's it. You graduated, right? You went into remission. But if we don't do anything after that, most patients' leukemia will come back. So the fourth major step is to then come back for some booster treatments. It's hard to think that you get through this hospitalization 4 to 6 weeks, you go home and you're going to be home for a couple of weeks and then come back for a booster treatment. But the good news is that for those booster treatments, you're in the hospital for about 5 days. You then go home, we work with you and your doctor, and you receive blood transfusion support once or twice a week. You usually see the doctor twice a week, get blood counts checked, get transfusions if you need them. If you have a fever, you come back in the hospital, but we have you on some antibiotics by mouth to try to prevent that. And usually that hospitalization is very short. Patients will recover about 3 weeks from the start of that treatment. We give them another 2 or 3 weeks off before their next cycle, and people usually receive anywhere from 2 to 4 cycles of the booster treatment over a period of 4 to 6 months. One of the things that many of our patients ask us about are bone marrow transplants. First of all, bone marrow transplants frequently these days are blood transplants. We use the blood instead of the bone marrow. So BMT is still fit, so it's blood and marrow transplant. But many patients with AML don't need bone marrow transplants from the beginning. Those are reserved largely for people that have the risk factors that are associated with a high risk of the leukemia coming back over time, or for patients who don't go into remission initially, or for anyone whose leukemia comes back over time. Once you're in remission, we'll be following you very closely. The highest risk of leukemia coming back is over the first 2 to 3 years. Patients who are in remission and disease-free at 3 years, there's a very, very good chance, greater than 90% chance that their leukemia won't come back. So the high risk is in those first few years, and we'll be monitoring your blood counts closely during that time. You'll obviously let us know if you have any problems. The problems will be the same ones that bring you in: infection, bleeding, or weakness and fatigue from anemia. The good news about acute leukemia is patients who do go in remission can frequently return to totally normal function. They can have very normal lives. They do not have a lot of long-term side effects in most cases. So if people are in remission, remain in remission, they very much can get back to a normal life. We spent a lot of time going over the details of acute myeloid leukemia. I'm going to talk briefly about acute lymphoid leukemia, or ALL, the one with the other middle initial. So the lymphocytes are the white cells that help fight chronic infections, such as respond to your flu shot, things like that. Much less common in adults. It's the most common of the acute leukemias in children, but it's only about 20% of adult acute leukemia. The approaches are somewhat similar. The way people present with infection, bleeding, and weakness from fatigue and anemia are very much the same. The diagnostic approach is also very much the same. You have to confirm things by bone marrow studies. It's confirmed by the flow cytometry, immunophenotyping. Chromosomes are important. There's a particular one here called a Philadelphia chromosome that you can see in chronic myeloid leukemia, but you can also in acute lymphoid leukemia, which may be a little bit confusing. That's very important to confirm because we have different treatment for that group. So the approach is through the initial treatment, trying to wipe out the leukemia with an intensive treatment in the hospital, usually somewhat shorter than acute myeloid leukemia. People are frequently in for 3 or 4 weeks. You may receive something called Neupogen or Neulasta to stimulate your white cells to come back. That's a safe drug in acute lymphoid leukemia because we're worried about the lymphocytes, and Neupogen or Neulasta stimulates the myeloid or the other cell line and helps you recover quicker, clear any infections, get off your antibiotics, and go home a little quicker. So the good news about ALL, if there is any good news about any leukemia, is that your hospitalization is somewhat shorter. You do not do that bone marrow in the middle. We treat people, do a bone marrow at the end when their blood counts recover. They come back, patients with acute lymphoid leukemia come back for more consolidation treatments, but frequently for shorter ones. And the real differences here, usually it's about 6 total courses of treatment. Hospitalizations, like the AML patients, are usually for 3 to 5 days for the consolidation treatments. We have to follow your blood counts as outpatients in between times. But the things that are a little bit different with ALL are really the risk of disease in your central nervous system or in the brain or spinal fluid. So one of the additional things you get is this treatment directly into the spinal fluid. We do a lumbar puncture or a spinal tap, check it for leukemia cells, and we put chemotherapy directly into the spinal fluid. And we do that a number of times over the 6 or 8 months of your first treatment and your consolidation treatment. We usually start with the consolidation or booster treatments, and we do that anywhere from once a month to once every couple of weeks to try to prevent infection, prevent leukemia cells from getting into the spinal fluid. With that treatment, it's only about 5% of patients that have that complication. Without it, it would be 30 or 35%. So it's very important to get that done. And most patients tolerate that relatively well. The other thing that's a little bit different with ALL is there's maintenance treatment with ALL. So once you finish these booster treatments after 6 or 8 months, there are good data that maintenance treatment or ongoing treatment is very important in ALL. That's different from acute myeloid leukemia. And that maintenance treatment is, relative to the other things you go through, is relatively well tolerated. The most common regimen people use is an outpatient regimen, 5 days of steroids given by mouth, dose of vincristine or one of the drugs you take once a month, every 4 weeks as an IV injection, and then 2 drugs, 6-mercaptopurine or pyranethol, you take every day as pills. And that's probably the hardest one for you, but it is important, so remember to take those. And methotrexate you take as a pill once a week. And that goes on for anywhere from 18 months to 2.5 years. So people take 1.5 years to 2.5 years of that treatment in general, but it does make a difference in decreasing the risk of your leukemia coming back. You will be going to the doctor's office once a month to get your injection, have your blood counts checked. Early on, we might check your blood counts every couple of weeks to make sure we don't knock them too low, and we adjust those pill doses. But on the whole, people tolerate this treatment. Many patients are back at work, back to their normal activities during this time, and have a very good quality of life. But it is important to decrease the risk of the leukemia coming back. The other thing I want to mention very briefly about the initial induction therapy is the drugs are different. Vincristine is a drug given weekly for usually 4 weeks. Daunorubicin, which is the anthracycline, or idarubicin, is given the first 3 days, similar to AML, but there is no cytarabine. Instead of that, we may or may not use cyclophosphamide, and there's a drug called asparaginase, which is a shot that you get twice a week for about 3 weeks. So those treatments are different, and the consolidation treatments are very different from AML, but the concept of wiping out the disease, letting you grow back and go into remission, and then doing some booster treatments is very much the same, AML and ALL, and the differences being the treatment into the spinal fluid and the maintenance treatment at the end to try to maintain those remissions. You all want to know what questions you should ask your doctor, what questions you should be asking, because it's an overwhelming diagnosis when you first hear it. Important things to know are what are the prognostic factors. Many of those may not be available to your doctor for a couple of weeks, the chromosomes and the molecular studies, but ask them when those will be available and how you will learn that information and share that information. Many of you want to know, do you need a blood and marrow transplant? That'll be driven largely by those prognostic factors we just talked about. And you'll want to know at what frequency your doctor expects to follow you as you go into remission. Your important part also is to make sure you share with your doctor any concerns you have so they can answer those questions. You don't spend energy worrying about things. They will know the answer, they'll help you address them, and knowledge is a powerful tool. Leukemia is a very scary diagnosis, and certainly acute leukemia is a very scary diagnosis. It can be very disruptive to your life. You think you have a cold or sore throat or something, and suddenly you're diagnosed with leukemia and you're in the hospital for 4 to 6 weeks. Just understand that 4 to 6 weeks is very important because of dealing with those serious complications like infection and bleeding. When your blood counts are low and you have no reserves, it's incredibly important that you let your doctor know if you have any signs of infection. You need to work with us. You have resources available to you. Guideposts for Strength are one of those very important resources to help you out. You have many others. Please take advantage of them. Above all, please let your doctors know this is a disease where being attuned to any infection risk, helping deal with those quickly is important to your survival and can make a big difference.